Alright guys, this is Caesar with Nursing School Made Easy, and again we're continuing with our lecture on arthritis. Focus today is going to be on rheumatoid arthritis, or RA. Now, for your NCLEX, the main thing that you want to remember is that rheumatoid arthritis is a systemic autoimmune disease. Now, we're not going to get into the details of it. I just want you to remember the main points. So let's focus on those main points. Again, rheumatoid arthritis is a systemic autoimmune disease. You must understand that one, it is systemic, and two, it is autoimmune. So let's break that down. Systemic, your whole body may be affected, and we'll get into that a little bit later with our signs and symptoms. Autoimmune disease, or autoimmune, means that it is your own body, in this case your own immune system, attacking your body. More specifically, the connective tissue in the synovial joints. Again, the connective tissue in the synovial joints is what is affected, and what will result is inflammation. Okay. This is different than osteoarthritis. Yesterday we talked about osteoarthritis, and we also said that there was little or no inflammation in osteoarthritis. And again, osteoarthritis was due to or caused by wear and tear, by overuse. And rheumatoid arthritis, it is caused by, again, an autoimmune disease. And in rheumatoid arthritis, there is inflammation in the synovial joints. In fact, there's gross inflammation or severe inflammation. The other thing present in rheumatoid arthritis is something called rheumatoid factor. So if on the NCLEX exam you see something like rheumatoid factor, that should let you know that they are talking about rheumatoid arthritis. And again, it is a systemic autoimmune disease. So let's focus on some signs and symptoms. Now we're going to talk about the inflammation and why that is important. So remember for now, neutrophils as a side note. So signs and symptoms. Number one, you would have weight loss. Number two, generalized stiffness. Number three, pain. This will be very big. Number three, pain, okay? Number four, inflammation. Like we talked about here. Now this is going to be warm to touch. 5. Now, due to the inflammation, the stiffness, and the pain, you will have decreased range of motion. Now again, we talked yesterday about how osteoarthritis is caused mainly by wear and tear, by overuse. And so it just depends on which body it is that you're using, which joint you're using. It might be the left knee, it might be the right knee, it might be the right shoulder, elbow, whatever the case may be. So in osteoarthritis, maybe only one joint is affected. In rheumatoid arthritis, the inflammation occurs bilaterally, meaning on both sides of the body. Your left side is just as equally as affected as the right side. Number 7, the spine is usually not affected. Remember yesterday we talked about in osteoarthritis, typically the cervical and lumbar spine are affected, again due to that weight bearing on those vertebrae. But again, in rheumatoid arthritis, the spine is spared. Number 8, stiffness increases with inactivity. So with these patients, you want to tell them to remain active as much as possible. Of course, you're not going to make them run a mile. You're going to have them do some type of activity, get a little bit of rest, do some more activity, and again, this is just to promote or to maintain whatever little range of motion they do have. Number 9, the stiffness, the pain, the inflammation, the decreased range of motion, the fact that they are becoming less active is going to cause muscle atrophy. What muscle atrophy is weakness, deterioration of muscle. The muscle gets smaller. So just imagine somebody that may be on a cast for a broken leg, broken arm, whatever the extremity is that was fractured. Typically, if you compare it to the unaffected side, you'll see that the fractured side is smaller than the unaffected side because, again, that muscle, that arm, that leg was not used. Therefore, the muscle gets smaller. It atrophies. Okay, in this case, the patient cannot do the activities that they were performing before. Therefore, the muscle will get smaller. It will get weaker. 10. Destruction of tendons, resulting in something called subluxation. And this is due to the severe inflammation, the severe swelling. The swelling will be so drastic that it will actually begin to destroy the tendons around it. And this will come into play later on when we talk about our interventions, because that patient may need some type of brace, some type of splinting to prevent subluxation from occurring. To get a better image, just Google what subluxation is. 11. High titers of RF, or rheumatoid factor. You know, we talked about how this is very specific to rheumatoid arthritis only. 12. Rheumatoid nodules. Now these may become masses. These are just glandular masses. Now these have a potential of becoming infected, and these can be throughout the body. They could be in the eyes, they could be in the skin, they could be in the hands. Again, the entire body is affected, hence again, systemic autoimmune disease. I don't really want to get into the specifics, I just want you to remember rheumatoid nodules. Okay? So again, if you see rheumatoid nodules anywhere on the NCLEX, it's talking about rheumatoid arthritis. 13. Dry mouth. And also decrease in maybe tear production. The question is why? Well, I just talked about rheumatoid nodules. Some of these nodules may actually go into or be around the tear ducts or the salivary ducts, causing some type of obstruction, some type of occlusion. Therefore, tears will not be able to be produced, and saliva will not be able to be produced, again causing a dry mouth or decrease in tear production. 14. Splenomegaly. 15. Pulmonary disease. Again, this is due to those rheumatoid nodules, these masses. If they become, or if they develop in the lung tissue, you'll have pulmonary disorders, problems with breathing, 16 cataracts. And again, this is due to those rheumatoid masses, those rheumatoid nodules affecting the eyes. So again, this is a systemic disease, so your entire body is affected. Now, let's talk about a few diagnostic studies that you might see on the NCLEX. Sorry about the mess here, just trying to save a tree. So I'll continue to use this piece of paper. So let's talk about diagnostic studies. Okay? One, you do some blood work, you will note that the patient is positive for rheumatoid factor. This occurs in about 80% of patients diagnosed with rheumatoid arthritis. Number two, if they were to aspirate some synovial fluid, you would find that the synovial fluid would be straw colored. Remember that. That may be on the NCLEX. Number three, increase in WBC. Now why? Well, in the very beginning I told you to make a side note about neutrophils. Well, why? Well, again, this is an autoimmune disease. And again, I'm not going to get into the specifics about it, but what ends up happening is there is inflammation in your joints. The neutrophils will come in and they will mistake your joints for as being foreign, and they will release enzymes that will end up breaking those joints down. So you will have an increase in neutrophils. This increase in neutrophils will cause your WBC, or white blood cell count, to be increased. And more specifically, if you were to check your WBC, what would be elevated is, again, the neutrophils. Now, what are some interventions that you can do? Let's focus now on interventions. Number one, pain management. You want to control the pain. Again, there's severe swelling, severe inflammation, some subluxation going on. So of course your patient is going to be in pain. So make sure you treat that pain accordingly. You want to keep them as comfortable as you possibly can. Number two, you're going to maintain joint function. You're going to try to prevent joint deformity. The reason, or the way that you're going to do that, is by some splinting or maybe a brace. And we talked about how patients may suffer from subluxation. Again, the swelling is so severe that the tendons around the joints give out, and then you'll see maybe some dislocation going on. So you want to prevent that. You want to prevent that by splinting or bracing whatever the body part is. You can do some heat and cold therapy. The other thing you can do is you can encourage them to maybe do a warm shower in the morning. Again, this would be some type of heat therapy. Now, the other biggie is you want to tell them to avoid complete bed rest. You do not want to make them completely inactive, because they're going to lose some of that range of motion that they do have. So you want to increase as much activity as they can possibly do. And of course, you're going to do short breaks in between that activity so that they do not get completely worn out, completely tired. 7, you're going to provide a firm mattress. A biggie here is 8. You will never place pillows under knees. Never, ever, ever. Now why? Okay, you're trying to prevent subluxation. So again, you're trying to have them be in a position where joints aren't bending more so than they already are due to the subluxation. So if you begin to start putting pillows under knees, if you do not give them a firm mattress, the whole purpose of a firm mattress is to maintain the joints in a specific plane. If you do not do these two things, well, what will end up happening is you'll end up causing more subluxation. So you want to avoid that. And so you want to promote positions where their extremities will be extended. And again, the whole purpose of this is to prevent subluxation. So they can even lie in a prone position from time to time, meaning they're going to lie face down on their abdomen. The other thing that you can suggest would be something, this would be, of course, be when they're in a home setting, is to get things like electric can openers, maybe instead of using shoes with shoelaces, to have them use Velcro shoes. And the biggest thing that you can do for your patient, aside from pain management and promoting good splinting care for them to prevent subluxation, is you want to make sure that you provide some form of psychosocial support. A lot of these patients are young patients, and they may have been completely active, and in a few months or years they have lost complete mobility, complete range of motion of their upper and lower extremities. So this is something that you definitely want to be aware of. You definitely want to take special care of these patients, because again, they are undergoing a lot of different issues with this type of pathology.